Hey everybody, this is Eric with FlightBridgeED. I wanted to start off today's podcast and just thank everybody for their involvement, for posting their comments on Facebook, for posting their comments on Twitter, for following us on both websites, and for registering for the forums account. Remember, we do have all these podcasts published on iTunes, so you can download these for free. You can download a podcast program on your iPhone and have subscribe and have these podcasts uploaded automatically. So we're really excited about that. We encourage you to get involved. We encourage you to spread the word. All this education at this point is free. We are planning on providing CEU hours on these podcasts and some other educational opportunities that will be subscription-based. However, you still will be able to access all of these educational tools for free. You just won't be awarded CEU hours. And this is going to be very cheap and very affordable. So we'll let everybody know when that happens and when we're getting close to that. For today's podcast, I'm going to probably try to spend about 15 or 20 minutes, and I wanted to talk about post-sedation management. And I think this is a really important topic. I think especially when new crew members or new paramedics and nurses get into the HEMS field, helicopter EMS field, or if you're flying fixed wing, you may or may not have been exposed to some of the medications that you're going to be exposed to. And you may or may not have had protocols that allowed you to give a lot of sedation and a lot of aggressive pain management. On the same boat, you may have never RSI'd a patient. So there's a lot of medications. If you've listened to the podcast on RSI, you know that there's a lot of medications we use in the RSI situation that can cause poor outcomes. You know, if we give too much Versed, we give too much of certain medications, and we don't do those correctly, we don't understand the pathophysiology and the action for each medication, things can kind of go wrong. So this podcast is strictly going to be on post-sedation management as it relates to primarily intubation and ventilator management. So how do we provide good analgesia, so pain management, and how do we provide good sedation or amnesia for these patients that are intubated. So let's first define sedation and pain management. First, we have sedation, and that's basically what we're doing is we're giving a medication. So medications would be Versed, Valium, Ativan, but the primary medication that we would give in this situation is going to be Versed. Versed causes a block of upper level awareness, right? It causes amnesia and hypnosis, and so that's where we use that for post-sedation management, so they're not aware of what's going on. All right, standard dosing range is anywhere from 1 milligram, up to 10 milligrams is kind of the dosing range. Probably primary dosing range is anywhere from 2.5 to 5 milligrams. Is a pretty standard adult dose if you're giving it for sedation. And I would always steer on the side of caution. Start with 2.5 milligrams, see what it'll do, because you will have some blood pressure effects. It does cause some vasodilation, and it can precipitate or increase your hypotension. How do we use these medications as far as Versed in our RSI? Well, in some protocols, you may use Versed for the induction aspect, so prior to giving your paralytic, like succinylcholine or rocuronium. Nowadays, though, we have etomidate, and etomidate is used for that induction. And etomidate is, like if you listen to the RSI presentation, is a hypnotic, right? And it's not a benzodiazepine. So Versed would come in post-sedation wise. So after we've intubated the patient, we need to continue giving the patient a medication that's going to blunt that upper level awareness. So that's where the Versed comes in. Well, what about the pain management aspect of it? Well, studies have shown that through brain studies and things like that, that intubation, laryngeal stimulation with a laryngoscope blade, intubation of itself, placing an ET tube in the back of the throat, is extremely, extremely painful. It's comparable to second and third degree burns. It's that painful. So probably 7 or 8 years ago, for me anyway, and this may have been around longer than that, we started using fentanyl in our RSI protocol. So we would give our lidocaine, let's say, for a head injury patient, and we would consider atropine for that bradycardia. At this point, we would give fentanyl, and the fentanyl dose for RSI is prior to induction is 3 micrograms per kilogram. And remember, fentanyl is a very potent opioid narcotic. It's 100 times more potent than morphine. So to give you an idea, 100 mics, it's measured in micrograms. 100 mics of fentanyl is equal to about 10 milligrams of morphine. One thing about fentanyl that's really good is it's very lipid soluble, so it passes through the blood-brain barrier very easily, and so the absorption is very quick. It's very stable on blood pressure, very stable on mentation, and doesn't cause any precipitous drop in respiratory depression or anything like that. And I think studies have shown that you start having respiratory depression problems at 5 micrograms per kilogram. So to give you an idea how much of a dose that is, that's in a 100 kilogram patient, that's 500 micrograms of fentanyl, which would be equal to 50 milligrams of morphine. So you can see that it's a much better pain management drug, very stable. It's excellent. In the sense of RSI, why are we giving the fentanyl? Well, again, we're giving the fentanyl for 2 reasons. It's a very painful procedure, and 2, in higher doses, in the 3 microgram per kilogram dosage range, fentanyl has sedative effects. Okay, so again, you're blocking that sympathetic stimulation, and you're helping with that sedation. So that's where the fentanyl comes in. So in RSI, we give our fentanyl dose prior to intubation in most situations. Obviously, there may be some situations where you have a crash airway or you have an airway that's extremely unstable, and you might skip that step. But I really encourage you to always try to make an effort to do that. Let's go back to our sedative medications. What do they actually do? I said that they cause amnesia, all right? They also cause hypnosis, which is they make you go to sleep. They also reduce anxiety, and again, they block that upper level awareness of what's going on. So that's very important. To give you an idea, if you've never RSI'd a patient, what you're giving them a paralytic, and you're giving them a paralytic that's blocking. It's either competitive or non-competitive in nature. And so what I mean by that, if you've listened to my RSI podcast, you probably understand what I'm saying. If you haven't, I encourage you to do so. Paralytics are broke down into 2 categories. One category is non-depolarizing neuromuscular blockers, and the other one is depolarizing neuromuscular blockers. So the standard, probably most popular paralytic for induction is going to be succinylcholine. And succinylcholine is non-competitive. And what I mean by that, it is a depolarizing neuromuscular blocker. So succinylcholine is made up of 2 acetylcholine molecules. That's how the chemist made the drug. And when you give the succinylcholine, those acetylcholine molecules, which they flood the system and they seat in that neuromuscular junction and cause a rapid firing of all the muscle neurons, okay? And that's where you get what's called fasciculations. So that's a depolarizing neuromuscular blocker. And what it does is it causes paralyzation all over. But if you have not given your patient any sedation, right? We want sedation that causes hypnosis, it reduces anxiety, and it causes amnesia, then they're going to be awake. They're not going to be able to breathe. Their lungs are paralyzed, and they're going to be aware. And can you imagine how that must feel? They would, basically feel like they couldn't breathe and they would be suffocating. So it's really important to give a good dose of some type of sedative medication. So giving the fentanyl, which has the pain aspect of it, has the sedation aspect of it, and then you're also giving an induction agent, which is usually going to be etomidate, which has that hypnosis side of it, giving your succinylcholine at that point. So you've treated the pain, you've treated the sedation aspect, you've given the paralytic, okay? So now we need to think about, once we've given the paralytic and we've intubated our patients, what do we want to use for post-sedation management? And that's what this whole podcast is about. There's different medications that are used. Benzodiazepines are the medication of choice, and so we have 3 of them that we can choose from. Versed, which is a little bit more potent, a little stronger in effect. You have Valium, and you have Ativan. And for most protocols that I've worked under and seen, Versed is probably going to be used the most. Again, you need to watch your blood pressure. You can always augment blood pressure with giving a fluid challenge. looking at your pathophysiology as it relates to what's going on with the patient. But there's no patient out there that's not going to benefit from giving a little bit of fluid, 250 to 500 cc's. So giving a little fluid, augment that blood pressure, and give your sedation. All right? The whole point of this podcast is I want to really change the culture out there where I don't think you need to be giving post-sedation paralytics or longer-acting paralytics after you intubate somebody. Okay? We need to be managing our patient's sedation and pain with fentanyl and Versed or fentanyl and Valium. And it's very important. If you manage your patients aggressively in this way, you shouldn't, for the most part, need your longer-acting paralytics. I will give you a few scenarios or a few reasons why you may, but I think for the most part, you can get by with being aggressive with your pain management and your sedation. Okay? Let's take that a little further. Which one is more important? And I think for the most people, and even me, a few years ago, I would have said Versed is more important. The benzodiazepine, the medication that causes the hypnosis, that causes the amnesia, that causes, the reduced anxiety. But it's actually the other. It's fentanyl. And the reason why is because, again, remember, this is a very painful procedure. Having an ET tube in the back of your throat when they wake up and feeling that anxiety and feeling that in the back of their throat has got to be horrible. So we really want to blunt that sympathetic response from the pain. Remember, an ET tube in the back of your throat, the laryngeal stimulation, things like that increase ICP as well. So we want to try to blunt that. We want to try to reduce that. Fentanyl is going to be your best option in that situation. So I challenge you to be more aggressive on your fentanyl doses, less aggressive on your Versed doses, okay? And for you that out there that are saying, well, what do you do in these patients that are hemodynamically unstable? What if they have a blood pressure in the 70s? What do we do? Well, here's what you do. We need to have these patients on the ventilator. You can refer back to my ventilator podcast, and I talk a little bit about sedation in that. Your patients will, their clinical outcome will be a lot better if you manage the patient aggressively with fentanyl, and even if you held back a little bit on your benzodiazepines, because remember, your benzodiazepines are the medications that will probably drop your blood pressure a little bit more. So just withhold your Versed. Give more doses of your fentanyl. I'm not saying to go large doses. I'm saying go doses every 5 minutes. All right? So what's our dosing range for fentanyl post-sedation? Well, we said in the beginning of the podcast that your dosing for pre-intubation treatment with fentanyl is going to be 3 mics per kilogram. Well, when you get into the pain management aspect, post-sedation management, most protocols are going to say 1 microgram per kilogram or something similar to that, 1 to 2 micrograms per kilogram. So it's kind of it varies, and you can tailor that to each patient. Again, I was always taught to start low. I got to give a shout out to my paramedic instructor back in the 90s in Oregon. Her name's Leslie Huntington, phenomenal instructor, one of the best instructors I've ever seen. And that was one of the things that she hammered us on was you can always give more, give a little bit, test it out, see what's going on, and then you can be more aggressive with your medications, regardless of what type of medication it is. So with Versed, I'm the type of person, if I'm giving it on a conscious patient for anxiety, I'm going to probably start with a milligram. I'm going to see how they handle that milligram, and then I'll go from there. Because I definitely don't want to cause them to stop breathing, which I've done that before. I've done it quite a few times where patients don't respond to the benzodiazepines like you think they will. You give them a small dose of Versed or Valium, and they stop breathing, right? And so you got to bag them for a few minutes, and then they come back up. Hemodynamically unstable patients with lower blood pressures, augment that with fluid, give them fentanyl, give them lower doses. You can go 25 to 50 mics every 5 minutes and give them some fluid, and I think you're going to find a very happy patient, a patient that's pain-free, that's more comfortable. They're going to be easier to manage on the ventilator. They're not going to be waking up. They're not going to be biting on the tube. They're not going to be combative. We got to remember, too, in the helicopter industry, we don't want a combative patient. We don't want a patient reaching for things or grabbing for things or pulling IV lines out, things like that. We want a well-managed, good sedation package and analgesic package on board. Valium is the same thing. Dosing range is anywhere from 1 to 10 milligrams. You don't really see Valium used a lot in this setting. You can use it. It's going to be pretty much similar to Versed. Ativan, again, the same thing. Ativan, you're going to give 1 to 2 milligrams IV, and for the sedative aspect of it. We need to be given, though, again, more fentanyl and less sedation. And I think you're going to realize that approach will give you better patient outcomes. It'll be easier to manage. So what other medications do we have at our disposal? Well, let's throw a few out there. What would you use for a neuro patient? What medications could you use for a neuro patient that would give you good blood pressure control? It would give you good hypnosis. It would give you a short half-life, and it would allow you to easily control your patients. Well, that medication is Diprivan, and I know a lot of people out there don't like Diprivan. It's a medication that can kind of get you into trouble. It can cause a real precipitous drop in blood pressure. It wears off very quickly. So if you're not watching your patient, if you run out of medication, if your drip runs out, your patient will wake up really quickly. So here's how I kind of play that. I think it's an excellent medication for head injury patients. Some helicopter services carry Diprivan. I know I carried it in Oregon when I flew for Mercy flights, and we carried Diprivan. Other programs may not, but you may see this medication in a transfer situation with a stroke or a head bleed or something like that, where you have Diprivan hanging for that sedation hypnosis. And it's excellent for that situation because a lot of times their blood pressure is high. It's excellent to control that blood pressure. When you get them to the receiving facility, the neurologist or neurosurgeon can turn that off, and you have an instant neural exam. Whereas if you had to paralyze this patient with a longer-acting paralytic like vecuronium or rocuronium, and you paralyze them and you didn't time that correctly, it might be 30 to 45 minutes before the neurologist can assess them. And if you're talking about a stroke situation or something where they need surgical intervention, time is everything. So, for you flight crew members out there, a lot of times we have a lot of pull when we're in these smaller ERs. They listen to us. They feel like we're a lot of times a big part of the patient care decision making. So you can recommend things. Hey, why don't we hang Diprivan on this patient or whatever? And most of the times they're going to go with you on that. Obviously, we want to watch the medication closely. We want to watch the blood pressure closely. I always recommend drawing up, a 10 cc syringe of it just in case you have a problem, you run out or whatever. I had that happen one time in a fixed wing where I wasn't watching the bottle closely, and the guy ran out of the medication. The guy woke up in the doorway, and so always have a backup, have things set up correctly to where you can give some medication if needed. So let's recap fentanyl again. Remember, fentanyl is extremely potent opioid. It's 100 times more potent than morphine. 100 mics equals 10 milligrams of morphine. And so for you medics out there that have never used fentanyl, I really encourage you to start using it first line for all pain management, whether it's a trauma situation or whatever. It's excellent for trauma. It's excellent because you don't have, again, the precipitous drop in mentation, blood pressure, and you can control the pain really, really well. All right? Okay, so if you had to give a longer-acting paralytic, let's talk about a few instances. Obviously, we have patients out there that we transfer, we fly, that whether it's trauma or medical transfer or medical scene flight, trauma scene flight, that are on chronic benzos, chronic narcotics, right? And they're on these massive doses. Well, these are those types of patients that no matter how much fentanyl you give, how much Versed you give, it may never touch their sedation or their pain to the point where they're comfortable on the ventilator. They may still be combative. And so in that situation, our safety as flight crew members is number one. And so you always need to put your safety first. So in that situation, I would definitely advocate giving vecuronium or rocuronium as a longer-acting paralytic, right? Remember from the RSI podcast, vecuronium is a It's a non-depolarizing neuromuscular blocker, so it's a competitive blocking agent. And what I mean by that is instead of the acetylcholine molecules like in succinylcholine flooding those neurosynaptic clefts and filling that space with acetylcholine, Vecuronium blocks that from happening. It basically puts a big old shield up and doesn't allow that. So you don't have the fasciculations, you don't have any problems. The half-life is 30 to 45 minutes, so it's longer acting. So again, if you are going to use this and you're flying in the helicopter, try to time this to where you do it to where maybe when you deliver them to the ER, you may only have 5-10 minutes more of paralyzation effects of the drug. Obviously, you can't always do that, and I understand that. But always try to be thinking long-term. How is my treatment now? How is my medication that I'm giving now going to affect the other clinicians, the doctors, the nurses, the trauma team, when they receive the patient, right? Our whole point is to get them to definitive care above us, and whether that's interventional radiologist in a stroke or an aneurysm, or a trauma surgeon, a neurologist, we need to always be thinking along those lines. The other medication is rocuronium. Rocuronium is, again, a competitive neuromuscular blocking agent, just like vecuronium. It's excellent. And so let's talk about those doses real quick. Well, if you decided to use vecuronium, your dosing is 0.1 milligrams per kilogram. So you're basically going to give a tenth of somebody's kilogram in weight. So if they're 80 kilograms, you're going to give 8 milligrams. Okay? If they're 100 kilograms, you're going to give 10 milligrams. Rocuronium dose is going to be 0.6 milligrams per kilogram. The way I kind of do this, obviously, we always give etomidate most of the time in an RSI situation. Your etomidate dose is 0.3 milligrams per kilogram. And so rocuronium is 0.6 milligrams per kilogram. Well, you already know what your etomidate dose was because you already gave it. So just double that etomidate dose, and that's your rocuronium dose. Okay, so that's your rocuronium dose. Again, if you can be aggressive with your pain management, with your fentanyl, and give a little bit of sedation, I think you're going to realize that you don't need the longer-acting paralytics. A few other patient categories that you may need some paralyzation. If you have a patient that's asthma, exacerbated asthma, or COPD, where their respiratory muscles are so fatigued, remember from the ventilator lecture, that causes what's called auto-PEEP, that causes air trapping. The patient just can't expel the air because their chest wall compliance is poor, and they have this rigidity and the fatigue. They've been working so hard to try to get all this air out, they can't do it anymore. So these patients, when you intubate them, they need to be completely paralyzed and rested for a while. If you obviously can give them fentanyl and Versed and keep them down to where they're not over-breathing the vent at all, then that'll suffice. But I think a lot of times it's hard to bring somebody down to that point. So a longer-acting paralytic might be beneficial in that situation. Again, look at every situation different. Assess what's going on, look at the big picture, and then make a determination. I would always steer you, though, to try to only use fentanyl and a benzodiazepine, and maybe go a little bit more aggressive on your pain management. All right, so remember, never withhold pain management or sedation. I don't care if the blood pressure is 76/40. You can still give a little bit. You can give 25 mics of fentanyl. You can do that every 5 minutes. You can augment this with, in a medical patient, you have them on a ventilator. They're septic. They need sedation, but your blood pressure is low. Well, what can you do? Well, you could start a pressor. You could start Levophed. You could start dopamine. You could start neosynephrine. And you can augment that blood pressure and give them a good sedation and pain management package. All right, so let's recap again. Where do we want, what if we have a patient that is a trauma situation, right? And if you've listened to my last podcast on fluid resuscitation and permissive hypotension, I talk a lot about we need to maintain a MAP pressure of 60 to 65, right? So how does that kind of coincide with pain management? Well, again, it's the same thing. You're going to augment the blood pressure. You're going to give a little bit of pain management, a little bit of sedation, and you're going to give just enough fluid to keep a map pressure at 60 to 65, right? We know a map pressure of 60 to 65 gives you a cerebral perfusion pressure of 70, thereabout, based on ICP. And we know that we have good tissue oxygenation in that situation. So we need to be thinking about our pain management. We need to be thinking about those things as it relates to our fluid resuscitation, our tissue oxygenation, and our overall shock status. So that's all I have for this podcast. I'm going to do a podcast coming up on the different types of shock, the pathophysiology as it relates to those types of shock, and how we can treat those and things to look for. Again, I want to thank you for listening in, and we really encourage you to get involved in the forums. It just takes a couple people to start a thread, and I know people are nervous, and I understand that. I want to learn from you. Hopefully you can learn from us. And I want to thank you again, and we'll talk to you soon.